So here in the third line setting, there are several options for treatment with no clear standard. Recently, options have really expanded in the setting with the availability of trastuzumab deruxtecan, or DS-8201, which was approved in December of 2019. This is an antibody-drug conjugate with the payload being a topoisomerase inhibitor. It's approved for patients that have received 2 or more prior anti-HER2 therapies in the metastatic setting. The agent was studied in an extremely or heavily pretreated population and showed an extremely high response rate, much higher than we would expect in that setting. A very important safety issue with this drug is highlighted in a boxed warning, which is interstitial lung disease, with fatal cases having been reported. So it's important to monitor patients for a cough, dyspnea, fever, or worsening respiratory symptoms. Another option in the third line setting that's particularly attractive, I would say, in this patient is neratinib and capecitabine. Recall that the patient had a taxane, trastuzumab, and pertuzumab in the first line setting. Second line treatment was with trastuzumab and tansine, and third line she progressed both systemically and in the CNS. So CNS or brain metastases are particularly problematic for patients with HER2 positive breast cancer. Some series indicate that as many as half of patients with HER2 positive metastatic breast cancer will go on to develop brain mets. And at this point in time, neratinib and capecitabine, I would say, is a good option. We know that neratinib, which is an irreversible pan-HER tyrosine kinase inhibitor, has CNS activity and was actually included in combination with chemotherapy in the CNS guidelines of NCCN as an option for patients with brain mets. And more recently, in February 2020, the FDA approved neratinib in combination with capecitabine in patients that have HER2 positive metastatic breast cancer and have received 2 or more prior anti-HER2 based treatments in the metastatic setting. So this approval was based on the phase 3 NALA trial, in which patients were randomized to receive neratinib plus capecitabine or lapatinib plus capecitabine. There was a 24% reduction in the risk of disease progression or death associated with the use of neratinib plus capecitabine compared with lapatinib plus capecitabine. Finally, another option that's not as yet approved, but hopefully soon, would be tucatinib, capecitabine, and trastuzumab based on the HER2 CLIMB study, which evaluated tucatinib, an investigational oral tyrosine kinase inhibitor, versus placebo added to trastuzumab and capecitabine for patients with previously treated HER2 positive metastatic breast cancer, including those with brain metastases. So what was unique about the HER2 CLIMB study was that this study included patients with previously untreated, treated and stable, or treated and progressing brain mets. Tucatinib is an oral tyrosine kinase inhibitor that's highly selective for the kinase domain of HER2 with minimal inhibition of EGFR, and this may alter substantially the toxicity profile to be more favorable. It substantially extended survival outcomes in the HER2 CLIMB study, and in addition, these outcomes were improved even in patients with brain metastases. So this will be an important addition to treatment options for patients in the third line setting when approved.